Hi, everyone. It's been a few months since we've seen each other on the Workers' Comp in Motion network. We'd like to extend a very warm welcome to all of you and say thank you so much for joining us for today's very special webinar themed Top 10 Things Workers' Comp Case Managers and Adjusters Should Know About Brain Injury. We're all very excited about today's presentation as Work Comp in Motion has recruited the very best to present on the topic, as I'm sure you'll agree with me once we get started. For those of you that don't know who I am, my name is Carlos Luna. I am the Vice President of Marketing for Risico, a Fresno-based workers' compensation TPA, managed care organization, and insurance provider. And I have the pleasure of being your host for the day. Workers' Comp in Motion would also like to give a great big thank you to our sponsors and co-hosts for today's webinar. They are Siegel, Moreno, and Stetler, Institutes of Health, NewQuest, ClaimLogix, MacroPro, ProCare, GenX, Corvell, iRatings, Learning Services, a Collage Rehabilitation Partner, Imber Court Reporters, DentalWorks, California Orthopedic Institute, Optum, MedRisk, Merge Investigations, Work Partners, and again, your host, Risico. Please be advised that CEU credits will be provided to all California claims adjusters, CCMCs, and RNs. We'll be announcing the raffle winners at the conclusion of the presentation, so be sure and stick around to see if you are a winner, although you're all winners in my book already for joining today's webinar. Now, you'll be pleased to know that we've allocated some time at the conclusion of the presentation for questions from the audience. So if you'd like to ask a question of our presenter today, please type it into the chat box in the bottom left-hand corner of your screen and press enter. I want to also mention that today's educational content is being brought to us by Learning Services, a Collage Rehabilitation Partner. And for 35 years, Collage Rehabilitation Partners has been the recognized expert for treating highly complex post-acute neurorehabilitation and neurobehavioral cases. The organization's longstanding success is based on its collaborative approach. And I want to give a very special shout out specifically to Amber Keithley for all of her hard work in pulling together today's program. You're going to want to give her a great big thank you as well. At the conclusion, you'll see what a high quality presentation she's helped to put together. Today's presentation presenter is Shannon Swick, Learning Services Chief Development Officer. Shannon is an accomplished executive with a history of success in team building, de novo startups, growth strategy, research, and outcomes management. Her extensive experience in clinical, operational, and sales leadership, along with her passion for business development and clinical outcomes, make her a natural fit for the executive leadership team of Learning Services and Collage's newly merged operations. Shannon is a limited licensed psychologist with over 25 years of experience working with individuals with traumatic brain injury. She has published numerous articles and presented nationally on outcomes with neurologically impaired populations. Now, without further delay, please help me give a warm welcome to Shannon Swick. Shannon?
So I'm going to go ahead and jump in and screen share. Thank you, Carlos, for the nice introduction. That was very nice. All right, thank you. I'm going to talk to you today about what are the top 10 things that work comp case managers and adjusters need to know about traumatic brain injury. So we're going to jump right in with number one. The definition of traumatic brain injury was updated in 2010 with the intent of making it easier to diagnose mild traumatic brain injury. So we'll start with what is that definition of traumatic brain injury? It is an alteration in brain function or brain pathology caused by an external force. Generally, you'll have at least one of the following signs: loss or decreased consciousness, loss of memory immediately before or after the injury, and neurologic deficits, which could be problems with balance, change in vision, confusion, disorientation. So one of those three is part of the definition of brain injury. Caused by an external force. So to be a traumatic brain injury, we're talking about an injury that's caused by something outside of the body, as opposed to an acquired brain injury, which would be an internal event. So an acquired brain injury would be something like a stroke. A traumatic brain injury is going to be caused by one of these four things. So an object striking the head, an acceleration or a deceleration injury. This is where, if you've ever been in a car accident where you were sort of thrown forward and then thrown back, hopefully held by your seatbelt, that would be that forward movement and then that back movement. And actually, when that's done at a high enough velocity, that's actually going to cause your brain to go forward within your skull and then go back. Penetration of a foreign object. This is mostly gunshot wounds, but it can be worksite accidents where something's actually penetrated the brain. I've seen things like rods that have fallen that have penetrated the skull and into the brain. So that would be a foreign object, or a blast injury. So we've learned a lot more about blast injuries in the last 10, 15 years through the military. And we know what kind of long-term effects those blast injuries have on folks who have suffered those. All right, number two, and I'm going to go kind of fast because we do have a fair amount to cover here, and I want to give you time for questions at the end. So we know what a traumatic brain injury is. How do we assess that? There are three primary ways to assess a brain injury: neuroimaging, neuropsychological evaluation, and functional evaluation. So neuroimaging is something that I'm sure you're all familiar with. There are a variety of types of neuroimaging. Sorry, I'm a little tongue-tied here. CT scan is the most frequently used. Generally, that's done in an acute stage. So if somebody goes into the ER with a suspected brain injury, they will likely have a CT scan, primarily because it's quickest route to see if there's something actually occurring in the brain. The second is an MRI. This is a more detailed image, tells us a little bit more about what's happening in the brain. Generally, this might be done after a CT scan shows that there is an abnormality. Then we might see an MRI to show more detail about where that condition is, if it's chronic, it gives us more information. The third is DTI, and that's essentially the most sensitive technique to look at the damage that goes throughout the brain. So the brain's connected by a series of pathways that sends messages, and that can show kind of where that injury will penetrate through those pathways. Gives us some idea about what kind of damage we might see, not just where the sort of individual lesion is, but kind of where the effect is spanned out to. And unfortunately, I recently had something occur in my own life where my mother had a brain bleed about 2 weeks ago. And so we originally had an MRI showed us where that was in the temporal lobe. And then later, before she left the hospital, she had the DTI, which gave us an idea. And in her case, fortunately, it was not real diffuse, and it was primarily localized in one area. But that gave us sort of a look at what occurred to her, starting with a CT scan in the emergency room, followed by an MRI, and towards the end of her stay, a DTI. So that's our imaging. The next would be a neuropsych assessment. A neuropsych eval is basically giving us information we know that from an image that there's a problem, and this is a physiological issue that we're seeing on those images. Neuropsych assessment is going to let us know what kind of impact that has had. So what residual effects have that injury caused? So it could be cognitive, it may be emotional, it could be behavioral. We see a wide variety. We could have physical deficits because of areas of damage in the brain. So that's going to start telling me more about not just the physical injury, but what we should expect the residual effect of that injury to be. And it's sort of our first clue on where we're headed as part of the rehabilitation process. I did make a note here that having a baseline neuropsych assessment is also very positive because it allows us to track over time if an individual is improving, deteriorating, gives us a good baseline of where we're starting from as we sort of go down that path of rehabilitation. And then we have functional assessments. So there's a variety of functional assessment tools. You're probably familiar with some of these, maybe not all of them. I did want to just make a note that you probably are familiar with the FIM. That's a score that they primarily use in the acute rehab setting. It has recently been replaced by the CARES tool. So if you haven't seen the CARE tool yet, you will start to see that as Medicare made that changeover as part of their restructuring of payment services. We're seeing all of those acute rehabs change those tools, and we see that sort of effect down throughout the rest of the continuum of care where we've seen changes in that tool. And the CARE tool has sort of subsets for different levels of care following acute rehab. In the space that learning services primarily is in that post-acute brain injury space, we as an industry primarily use the Mayo Portland Adaptability Inventory, or the MPAI. This is also a measure of functional assessment, really going to tell us what abilities people have, where they have deficits, looking at different indices for those, being their abilities, their adjustment, and their participation. Participation indexes are those things like, can they go to the grocery store? Can they manage their meds? Do they drive? Can they manage their money? So this is a tool that works well in the part of the continuum of care where we're starting to look at really putting somebody back out into a community setting. So preparing them to go home, or maybe in the home, and preparing them to gain that independence. Disability rating scale is a tool that was quite popular several years ago. Some people still use it. It's still a nice tool, but you're not seeing it quite as frequently. And the TQI was also another one of those tools that has sort of phased out over time. It wasn't the best tool for people who were at that higher end of functioning. It didn't pick up some of those deficits. So those are the three things that ways in which we do assessment post-brain injury. All right, number 3. Brain injury claims are among the most costly claims workers' comp carriers will see, and they're rising. I probably don't need to tell that to you guys, but I'm going to show you just a little bit of data. All right, so if you can identify and intervene very early in these mega claims, it's possible to really change the dynamic and change the outcome. Overall, we see that mega claims really are what drives your high cost cases in the comp area. So head injuries, brain injuries account for 30% of all of these claims that are in excess of $10 million. Even though they make up less than 5% of all claims. So these are the claims that really take a lot of your attention and a lot of management and really do well with case management. All right, this is a graph that came out from the Work Comp Academy showing that rise in mega claims. So this is showing claims that are reaching 3 million in the first 18 months. And you can see that, for many years, it stayed relatively flat, sort of creeping up, but you're seeing as time has gone on, and this study actually only has data through 2017, but you can see how that's rising, and more current data shows that continues to rise. In this study, they found the types of injuries that were most closely associated with these mega claims were spinal cord injury, brain injury, and burn injuries. All right. Why can mild diabetes so perplexing. So this is one that we're going to take a little bit more time talking about, because I get a lot of questions about mild TBI and why cases aren't moving the way that people think they should, why they may be taking considerably longer than expected. I'm going to start out by talking about what is the definition of mild traumatic brain injury. ACRM, which is an academy of rehab that most rehab providers and researchers participate in, redid the definition of mild traumatic brain injury fairly recently. So basically, a mild traumatic brain injury is a disruption of brain function in at least one of the following. So any period of loss of consciousness, any loss of memory for events immediately before or after the accident, an alteration in mental state at the time of the accident, and some sort of focal injury. So that focal injury could be, like we talked about before, slurred speech, blurred vision, strange gait. Any of those things could be a focal injury. We're really talking a mild traumatic brain injury at less than 30 minutes. So this graph you're looking at now shows you how brain injury is divided into mild, moderate, and severe. Sometimes a mild brain injury will be called a concussion. I think for many years people thought those were different things, and I think what we know now is that there's a little bit of a continuum of concussion, but those would fall in the mild brain injury category. So loss of consciousness of 0 to 30 minutes would qualify as mild. Moderate would be 30 minutes, greater than 30 minutes, but less than 24 hours. And then severe is greater than 24 hours. So we know that if somebody has had a loss of consciousness for greater than 24 hours, that there's going to be significant damage to their brain. A couple of different scores to look at that were also listed in that graph. About 80% of all brain injuries are mild. So when we talk about all of the brain injuries in the United States in any given year, 80% of those are mild brain injuries. Men are 2 times as likely to have a brain injury as women. And we see this in kind of little age clusters. So you see sort of an early age cluster of about 15 to 24, and then you start to see over 70. So in that over 70 group, you're seeing a lot of falls as the primary cause of these sort of injuries, especially these mild injuries. Not that you can't have a severe injury from a fall, but we do see in the mild area that there are a lot of falls. So below in this graph, on this slide, we're showing, the primary causes of those injuries are falls, motor vehicle accidents, striking or being struck by something. This could be being hit by a car. My son used to play baseball when he was in high school, and I can't tell you how many times I saw a player walk through the warm-up box where the batter was swinging and take a full blow to the head with a helmet on. But that would definitely be a struck injury. And then increasing assaults as the reason for these types of injuries. All right, just a few facts about mild traumatic brain injury. Over 1 million people will experience it in the US each year. Most will resolve within 3 months. So most people who have a mild traumatic brain injury will be back to their pre-injury state within 3 months. A small portion of this group will have more of a persistent issue related to it, and that would be symptoms that last 12 months or longer. Mild traumatic brain injury can also be associated with psychological or psychiatric conditions as well. Many people who suffer from a mild traumatic brain injury may experience depression, or they may experience PTSD, particularly based on how they received that injury. But in general, as we said before, most recover with very little intervention in a very short period of time, and most will return to work within the first 30 days. All right, so how do we diagnose this? So the DSM-4 has some criteria for diagnosing post-concussional disorder. And this is when you're maybe not seeing that resolve in a 3-month period of time or a 30-day period of time. So the first thing to be diagnosed is obviously you have to have a history of actually having some sort of event that caused a concussion. You're going to have to be experiencing some cognitive deficits. Most likely, those are in attention and memory. From experience, we know that with kids, it's a lot of times an attention sort of issue. With adults, it tends to be more a memory issue than an attention issue. So I've had a lot of parents when I practiced as my primary role. I treated pediatrics, and oftentimes one of the things that I would ask parents is, do kids continue to watch the TV shows that they watched before? Do they play the video games that they were playing? If they've stopped engaging in those behaviors, it's likely because they are having some neurologic issue around attention, and they can't sort of keep the thread to follow the TV show or to engage in the video games. So symptoms of a sufficient severity to interfere with social roles. So this means if you can't go to work, if it's somebody whose primary role is as a homemaker, if you can't keep up with sort of managing, the kids and the laundry and all those things that you did beforehand, or even a retired person who had a sort of a social calendar that they kept up in. If these things are things that you cannot do anymore, that would qualify under that diagnostic criteria. So in addition, we need to see the presence of at least 3 of the following that last for at least 3 months. So we're talking about things like fatigue, sleep disturbance, headache, dizziness, irritability, affective disturbance, that means kind of mood, personality change, or apathy, meaning sort of lack of interest in anything. So to really meet the diagnostic category, we have to have at least 3 of these, and they have to occur for at least 3 months. So we have sort of 2 types of mild traumatic brain injury. An uncomplicated mild traumatic brain injury is one that progresses like we talked about, that within 1 to 3 months it's really resolved, and about 80% of all injuries fall in this category that are mild. Complicated mild brain injuries are the ones that give us a little bit of trouble. These are the ones where I think many times people will take pause and think, why is this person having so many symptoms? Why haven't they gone back to work? They had such a mild injury. Don't really understand why this is going on for such a long period of time. And unfortunately, because I had to switch slides with Carlos, I had added a slide here. So I'm just going to tell you, instead of showing you the slide, I want to tell you just a little bit about a case that just came across my desk recently of an example of this complicated mild. It was a gentleman in his 50s. He was injured on the job. He was struck in the face with a bat as part of his job. So he lost consciousness for about 10 minutes. They took him to the ER. He had some, dizziness. His gait wasn't real steady. Had a little bit of trouble conveying what he was trying to say to the nurse and the doctors at the ER. Was there. They did a CT scan. The CT scan looked normal. They sent him home. 3 days later, he returned back to the ED because he was having great difficulty standing. His communication skills had deteriorated further, and he was worsening. So he wasn't recovering. He was actually starting to look worse. At this point, he had another CT scan to see if something had changed. CT scan showed no abnormalities. Went home for about a week, and at that point returned to the ED again with extremely bad headache. Could not walk on his own by this point, had to have assistance getting in there. And so they did a CT again, 3rd CT scan. Showed nothing, but they referred him to a physician, which he followed up with the next day. At that point, he had an MRI on that day. And we're about 3 weeks out now from the original injury. And that MRI showed a significant subdural hematoma. He ended up having to go in and have that evacuated and had a stay in the hospital for about 5 days post that surgical intervention. So sometimes injuries that look very mild in the beginning are not as mild as we think they are, because imaging doesn't always pick up the bleed at the time of the initial scan. A little unusual to see multiple repeats, but the type of injury he had really wasn't detected until he had that MRI. So this fellow's now had about a year of trying to deal with gait issues, really severe dizziness, headaches, and a lot of chronic pain issues. But it just gives you an idea of why some of these injuries are complicated, even though in the beginning they don't look like they're a very severe injury. And here are some factors that can influence the outcome and often result in poor outcomes with mild traumatic brain injury. So, people with increased age, older folks, will generally have a slower recovery and may have more residual deficits. People who have premorbid psychiatric illness may see an exacerbation of those illnesses post mild traumatic brain injury. Sometimes we see development of new psychiatric illnesses. We mentioned before something like PTSD or depression, people who experience chronic headache, dizziness, an inability to engage in sort of their regular activities often are at risk for depression. So those are things that can occur. There are things like compensation and litigation that can have an influence over these factors. Repeat injuries, very significant. It's why we have started to see lots of protocols around sporting events and concussion. You know, back in the day, I'll say, football players would have their bell rung and they would go on with the game. It was considered a part of the game. Now we know that those repeat hits do significant damage, and it gets worse with each one. It builds over time. So it's not like the second injury is not as bad as the first. It's probably, complicated significantly and on and on. And this is sort of what we see in that whole field of CTE, where we're talking about sort of that chronic brain issue related to repeated mild injuries. So the actual event that caused the injury wasn't significant. It wasn't like a gunshot wound or a fall from 15 feet, but it's cumulative. So because there's been 7 concussions, you start to see extreme damage. And as professional athletes have post-morbidly donated their brains, really been able to see the true effect that those have over time. So multiple injuries are problematic. If your kid has a concussion, make them sit out. We want them to heal fully before they're back in any kind of sporting event. People who have abnormal imaging are likely to have poor outcomes. People who expect to have poor outcomes, whether it be from their own perspective or their family has sort of set that expectation or a doctor sets that expectation, we can often see that influence it. And extracranial injuries, so things that have also caused damage to the skull, the face, the teeth. There's a very high correlation between facial fractures and traumatic brain injury. So not always picked up immediately, but there's a very, very high correlation. All right, number 5, brain injury as a chronic condition. So what we know now is that brain injury really looks more like a chronic condition than an event. So we've had in the past, we've talked about somebody having a brain injury as an event, but what we know now is that having that brain injury, if it's been a moderate or severe injury, is likely going to cause lifelong chronic issues. So this is the WHO definition of chronic disease, having one or more of the following characteristics. So it's permanent. A chronic disease is permanent, caused by non-reversible pathological alterations. It requires special training of the patient for rehabilitation and or may require a long period of observation, supervision, or care. So these apply to any chronic condition under the WHO, but you can see how this applies to brain injury because it is irreversible. When you've had significant damage to an area of your brain, there may be some healing, and we hope for that, but there is long-term non-reversible damage. Definitely requires special training. In a lot of the patients that we see, they are not able to go to just sort of a traditional outpatient where you might go for an orthopedic injury because they can't sort of function in that environment. They need a much higher level of structure. And many of them are going to require support and supervision for the rest of their lives based on the severity of their injury. We also know that TBI increases long-term mortality rates and reduces life expectancy. So brain injury as a chronic condition is associated with many other issues. I've listed just a few here. One that you're probably all aware of is increased incidence of seizure. So we will most likely see somebody on seizure meds early post-injury, and some people will be taking those meds for the rest of their lives. Sleep disturbance or disorders are very common with traumatic brain injury. We see a higher incidence of neurodegenerative disease, neuroendocrine disease. Someone may develop things like diabetes or thyroid problems post-traumatic brain injury. And then we may also see things like development of psychiatric illnesses, depression, anxiety, even some of things like you may see somebody who's become sort of bipolar and they're based on their brain injury and their inability to kind of control moods. So mood disorders are definitely can be a part of this. We also see non-neurologic type issues. So we see things like sexual dysfunction, bowel and bladder incontinence, metabolic dysregulation that can persist for months or years post-injury. So again, thinking about brain injury as an incident doesn't really tell the whole story. We really have to think about how this alters someone's life long term. So what we found over time in studies is that providing a disease management approach can reduce the overall costs and improve the outcomes. Basically, it's important for us to prevent as many of those issues as possible so that the person does not develop a more significant disability. I would say probably one of the things that we see most frequently is with diabetics. If they are engaged in poor management of the diabetes, we often see very costly changes and additional care needed related to that poor management, poor understanding of how to manage the disease. So that's just one example of how that can really inflate cost. It really applies to all of those conditions that we've talked about. All right, number 6, people with brain injury age differently and have decreased life expectancy. We touched on this a little bit before. So the model systems do studies related to long-term outcomes following brain injury. This is actually a result from 2014 when they were specifically trying to study life expectancy post-brain injury. So approximately 1 in 5 of the people that they did follow-up had died by 5 years post-follow-up. And this is primarily because these people are going to have been in acute rehab. We're talking about people who have a moderate to a severe traumatic brain injury. So 49% increase in death by the age of 80. 2.2 times more likely to die just in general than people without a brain injury. 1.5 times greater chance of survival after 1 year. So if people make it through 1 year post that traumatic brain injury, their survival rate improves significantly. However, we still know that they are going to have almost a 50-50 chance of dying at an earlier age prior to 80 than they would have if they had not sustained a brain injury. Some other things we learned in this study is that overall, older people have a poor medical outcome, poor functional outcome, or participation outcome. Younger folks tend to have poor emotional and mental outcomes. So we see some difference in people, maybe based on sort of what kind of life skills they had prior to the injury. Older adults seem to be able to cope with the changes and the emotional issues with those change in functions much better than young people, which, just makes sense. But what we see is about an 8% increase in severe depression, 14% misuse alcohol post-injury, 55% are unemployed. That's a really big number, especially when you're thinking about younger adults. And 57% have moderate to severe disabilities that last long term. So, is there something we can do about this decreased life expectancy? And there are ways to mitigate some of these concerns. They have greater risk for heart disease and cancer, so screenings are important. Greater risk for seizures, so we want to make sure that people are taking seizure meds. Accidental poisoning. This is where we would talk about folks who may need supervision long term that can't necessarily make good decisions for themselves. Sepsis, aspiration pneumonia, respiratory infections. These are all things that high quality care can help mitigate or even, keep from happening, or get early intervention so that we're not having very costly and very traumatic health effects to people who have had a traumatic brain injury. Number 7, rehab is a continuum of care for people with brain injury. So what we really want to think about here is that, again, when we talked about brain injury as a chronic condition, even in the earlier phases, we want to think about brain injury as a progression. So when somebody has, and we're going to talk more about kind of a severe brain injury, somebody goes, maybe has a life flight to an emergency room. They're then, they may have some sort of surgical intervention. They may just go right into an intensive care unit. They're going to be on sort of that med surg unit for quite a while. As they start to gain stability medically, one of two things are going to happen. They're either going to progress to the point where they're going to go into an acute rehab setting, or if their progress is somewhat slower, they may go into more of a long-term acute care setting. So this is where we're starting to branch off a little bit based on that outcome. Once they go through that acute rehab process, they're then going to get into a post-acute setting. So this is where does someone go post-acute rehab discharge from hospital. So they may need a residential setting, like we have at Learning Services and Remed. For a variety of reasons. It could be because there are some of those behavioral issues. It may be that there's still lots of physical deficits related to the impairment that they need rehabilitation for. And they may need, continued medical observation. Those folks who are kind of slow to recover are most likely going to go into the more subacute arena. And this would be where maybe a skilled nursing subacute, where we're sort of watching and waiting, giving them time, improving their medical condition for them to be able to participate in rehabilitation. Some patients may be able to go from the acute rehab to a home setting, and they would receive, home and community-based services, home health services, outpatient services. Those are going to be your folks who have pretty strong medical stability and probably not the type of behavioral or need for supervision issues if they're going to make that transition immediately from the acute rehab into the home. After those rehab phases, we're then going to be making a determination if the person has made great gains and they are a candidate for independent living and they're going to be able to kind of return to their previous life, or if they may need some additional supports. So maybe somebody is going to return to living with family members instead of living alone. Or perhaps they're going to be supported by a program where they may live in an apartment, but somebody makes sure that kind of all of their basic needs are met. Their meds are taken appropriately, they get their med refills, they're eating regularly, that level of support. And then those folks who have more long-term significant impairments are probably going to need a supported living program. This might be a group home setting where they have a higher level of supervision because they're just not safe to live long-term on their own. So I'm going to go in just a little greater detail about kind of the different arenas. So residential care following an acute rehab stay is usually there's kind of two types. There's a neurobehavioral rehab programs, and then there are neuro rehab programs. So your neurobehavioral programs are for those people who really have severe behavior problems following their injury. Lots of times these are going to be folks who have frontal lobe injuries, where you're going to see impulsivity, poor decision making. You may be seeing physical aggression, verbal aggression, that loss of control where they can't really manage their temper or their mood. These are people who are most appropriately placed in neurobehavioral programs. And the goal of these programs is really to get that behavior under control so that the person can progress to the rehab stage where they can do OT, PT, speech, and start to make those recovery gains in that area. But first, we have to address the behavior, generally through applied behavior analysis, neuropsychiatry, pharmacology, and then just very highly structured environments. We can oftentimes help people learn to regain control over their behavior. Neuro rehab programs are going to be very heavily focused on high intensity rehab from the very first day, really making sure that we're pushing the person through as quickly as possible to gain that, to regain their function, to walk independently, to do all of their ADLs independently. So this is a very active and aggressive rehab program. Our next general area are community-based programs. So traditional outpatient, these would be people that probably have more of your mild injuries, but may need PT, OT, some level of intervention. Home and community programs. Our home and community program focuses very heavily on high intensity rehabilitation as well. So people are going to get OT, PT, speech, psych, counseling in the home and community setting with a strong focus on community and return to work. And then we have day treatment environments. So day treatment environments are those types of programs where the patient goes in for usually 6 hours a day. They go in the morning, spend the full day working on a variety of individual and group therapies. It provides a level of supervision during the day so family members can work, but they're not folks who are going to need that overnight supervision. So they have a family or a home that they can go home and be safe in, but they need high structure during the day. And then supported living programs. These are those programs that we talked about for people who are going to need long-term support. And this may be behavioral or just based on their cognition that they're not going to be able to make good long-term decisions. So the rehab route is unique for each person, and I think that's important to remember. These cases are not going to progress always in a similar fashion. It's what one patient goes through and does very well may not work for another. People in brain injury rehab say you've seen one brain injury, right? You haven't seen them all because there's lots of nuance. But good data does exist to support that post-acute rehab, transitional rehab really does improve people's independence long term and reduces lifelong costs. So the better that we can get people post brain injury, the less money it's going to cost for health plans, comp carriers, their families, society in general because of Medicaid or Medicare funding. So we really want to focus on getting people better as early as possible and really going at those rehab programs at the right time. Number 8, how do you know if somebody should go to a skilled nursing versus an active rehab program? People who do well in an alternative to a SNF are generally people who are younger. Younger people generally don't do particularly well in SNF settings. People who have not participated in active rehab. So instead of going to a SNF, if they can go directly to active rehab, we're going to see a better outcome and that they can participate at 3 hours or greater a day in that rehab. So really the goals are to reduce that long-term disability, reduce overall cost, and younger folks generally are going to do better. CMS, has in their database that there's something like 250,000 people in nursing homes that have traumatic brain injury and would be better served in other environments. We've seen lots of waiver programs develop around this cause of getting folks out of SNF settings if they're not really appropriately cared for there. For those over age 65, how would we decide if they should go to a SNF or to a rehab program? So they're more likely to be discharged to a SNF from a hospital setting than younger people because it's just sort of considered the acceptable thing to do for people 65 and over. We do know that they tend to recover a little more slowly. They may stay in the hospital a little bit longer. However, evidence shows that intense rehab with these folks does improve their cognition and their physical functioning. And most older adults who receive acute rehab will return to their community setting. So if they lived in an independent home, they're most likely to return there. If they lived in maybe some sort of community living where there were some minimal supports or activities, they are much more likely to return there if they go to an active rehab program than if they go to a SNF. If they go to a SNF, there's a much greater likelihood that they will stay in that SNF long term. So the next fact is that spinal cord injuries are often associated with at least minor brain injuries. So about almost 30% of people who have a spinal cord injury will also have a traumatic brain injury. With a spinal cord injury, there should be a screen for traumatic brain injury. These screens may need to be motor free, meaning that some of the things that we do with neuropsych eval are things that we ask people to use their hands to do. And obviously that's not going to be appropriate for somebody who has upper extremity paralysis from spinal cord. Early detection of TBI in association with spinal cord results in better outcomes. What happens with brain injury, and we see this in orthopedic injuries as well, is that sometimes they're not detected early because the pressing issue in the acute stage is stabilization from that spinal cord injury. So we're not really paying a whole lot of attention to where they are cognitively. So we want to make sure that we do address that when somebody is stable from that initial injury. And we should know that if somebody does have that dual diagnosis of spinal cord injury and brain injury, they are going to have probably a longer length of stay in the hospital and in rehabilitation. Number 10, what we need to know for long-term cost management. Managing the continuum of care is essential. So to do long-term cost-effective management of these cases, we want to make sure that somebody is progressing through the continuum of care. So if they're going to start at a acute rehab, they may go to a residential program. We want to make sure that we have our eyes on what's that next step after residential. Can they go to a home program? Are they going to need some sort of support? But we really want to manage that process through the continuum. Centers of excellence typically give you your best value. Sometimes I think there's an idea that they cost more and should be avoided, but in general, they're going to give you the best value because you're going to have the best long-term outcome, which means the best overall cost reduction. Case management is essential to good outcomes. I can't stress this one enough. The person who's going to manage the continuum of care, make sure the person's getting the right treatment at the right time and the most cost effective, is a good case manager. They're your best partners. They're our best partners in our business, and just couldn't do this work without case managers supporting those patients to move to the next phase. And again, focus on long-term durable outcomes. Dollars that are spent up front will reduce long-term costs and enhance quality of life for the person with the injury. It's really a win-win. And if that's the only thing you walk away from today, I would still be happy that you can get to a win-win by managing these cases up front so that you don't have long-term costs and so that the individual has a high quality of life. Those things really do go hand in hand. Okay, I'm going to switch to questions. I'm sorry we got started a little late, so I'm a little bit pushing right up to the end here.
Okay, so I'm scrolling through the comments here. Let me just get through. By the way, to the general audience, I'm terribly sorry for the technical issues that we had at the top of the call. Please know we are going to be publishing a recorded version of the presentation that will be a lot more cohesive and a lot smoother. So please be on the lookout for that. And Shannon, thank you for being the consummate professional in wading through those issues with us. So I'm getting through the comments here. We are going to be sending out the presentation materials as well, in addition to the recorded presentation. So you will all get a copy of Shannon's slides. Here's a question. How can you tell when symptoms are being exaggerated, especially with headaches and memory? I have several claims with NLOC with more complaints than those with LOC. Any suggestions, Shannon?
Yeah, I think one of your best bets in that situation is to probably have a neuropsych evaluation. That's going to tease out the malingering from actual sort of impairments related to the injury. So my suggestion would be in a situation where you have some doubt like that and there isn't a loss of consciousness. Neuropsych tests are a battery of tests that are specifically structured to be able to pick up inconsistencies in responses, which would show you that somebody may not be being completely truthful and maybe exaggerating symptoms.
Great, thank you for that response. Next question is, how do we then distinguish between a post-concussional disorder and something more persistent like PTSD, anxiety, or dyspnea, and what treatment challenges are involved?
Yeah, I think, I think now we're actually at a better place to deal with these issues than we were, probably 10 years ago. There are a lot of post-concussive programs that have developed, some of them as part of hospital systems that are really able to focus in on that concussional period and help sort of move people through and determine what may be causing that delayed return to, I'll just say, life, whether it's a kid or an adult. They'll be able to tease out that psychiatric piece from your, more traditional expected sort of brain injury deficit areas. So I would say find a program that really specializes in that and has high quality, and your acute hospitals probably can refer you to those best programs.
Excellent. Can any other orthopedic injury aggravate a brain injury?
Can it aggravate a brain injury? I'm not sure I can answer that completely. That's probably a better question. I think what we see is it can definitely impact the rehabilitation process and slow recovery. If somebody has, for example, one of the things that we see frequently is non-weight bearing on both lower extremities. Um, that kind of orthopedic injury is obviously going to cause a delay in somebody being able to work on their ambulation. So you're going to see those sort of things. And then I think the other thing that you might see is associated with that is that delay and inability to sort of engage in those active rehab processes. You may see depression and some of those psychological issues sort of creep in because the person gets really frustrated that they are, they're not being able to move through that sort of recovery process.
Great. In the outcomes, what is the percentage of suicides?
I don't have that data from the model systems, but I'd be happy to look that up and maybe include that when we send out the presentation, because I'd like to send out the updated version, not the one we had today.
Great. And Carrie Fitzgerald says, will the notes be available for future review and reference? Absolutely, Carrie, they will. And big kudos to you, Shannon. Carrie says, very good talk, very informative and helpful for case management. And I agree with Carrie. You did such a phenomenal job today. We've got just a couple more questions. Is that okay, Shannon?
Yeah, sure thing.
Okay. Can the use of hallucinogenic mushrooms cause a spiral in someone's diagnosed, hold on a moment, in someone diagnosed with a TBI? And as further context here, this person began to go downhill drastically after beginning to self-medicate with non-prescribed meds. What are your thoughts on that?
Definitely, I don't know specifically to hallucinogenics, but I can tell you that in general, folks with traumatic brain injury do not respond well to any mind-altering substances. If they're in the recovery phase, you are going to see interference in recovery. And in the lifelong living phase, they typically are not people who are functional users. Even of things like alcohol, you might see people not be able to sort of be functional users. It's going to be more of a problematic situation. So generally not recommended at all.
Great insight. My friends in Utah, Paula Stauffer. Hi, Paula. She's asking, are you seeing an increase in referrals to concussion clinics without appropriate evaluation or prior authorization?
Well, we don't have particular concussion clinics, so I'm not sure that I can answer that question. I think that it's definitely an industry that's grown significantly, so it wouldn't surprise me that you're seeing a lot of referrals made to those clinics. A good assessment is probably a good thing, even if the person doesn't have a lot of residuals, because again, we talked about the neuropsych eval. Having a baseline is not always just great for us as treaters. It can be great for you as funders as well, because you're going to be able to see, like, if somebody has a concussion and this is their baseline, and then they have a neuropsych eval a year later and it's actually worse, that's going to be a red flag, right? So either something is going on physiologically that needs to be looked at, or something is going on with maybe ulterior motives. But having that baseline is a great investment. So I would encourage that in terms of just, it's going to protect you as well in the long run, to have that very solid, like, what is the starting point post concussion?
Well, thank you for that sound guidance. Do you have a list, or does a list of programs or providers that provide post-concussion treatment exist? And do you have access to that, Shannon?
We can send that out as a reference list with the materials we'll send to follow up.
Excellent. Great question, Helen. Let me see here. Vanita is asking, people who drink every day, that is alcohol, when they drink alcohol every day, how do they recover after traumatic brain injury?
Generally not well, definitely not recommended. Um, for a variety of reasons. In the early stages, it will actually interfere with that physiological recovery. And then, we talked about behavioral issues. We see alcohol exacerbate, all of the things that we see in people who don't have brain injury, where they are impulsive, they make poor decisions, they drive a car when they shouldn't. When you add a brain injury on top of that, you're just talking about worse decisions, worse outcomes. It's just not a good idea. And then the whole chronic condition of daily drinking is definitely going to be problematic because of that chronic condition. Again, if it's a chronic condition, throwing in any sort of factor that makes that worse is really a bad idea.
Well, thank you so much, Shannon, for taking the time to answer all those questions. We really appreciate it. And as you can see from all the comments, everybody loved it, found it extremely beneficial. And as a reminder to the audience, we will be disseminating the copy of the PowerPoint presentation from today, a list of the providers that was requested, as well as a link to the recorded webinar with the Q&A session here within the next 24 to 48 hours. Please be advised that your CEU certificates will be in the email, will be sent electronically here within the next 24 to 48 hours as well. And once again, WorkComp Partners would like to extend a great big thank you to our group of sponsors from today. I'm going to share, bear with me here. I am going to share the slide of all of the wonderful partners that we have. Bear with me here. I'm having to toggle a few screens. There we go. Okay, I'm sharing with you now. Ta-da! There we go. There's our list of sponsors: iRatings, Risico, Siegel Moreno Stetler, ClaimLogix, ProCare, NewQuest, and so on and so forth. Thank you all so much for your continued support of Workers' Comp in Motion. And now the moment you've all been waiting for, cyber drumroll, please. Here are our raffle winners for today. So if you see your name on this list of winners, again, you're all winners in my book for having sat through such an awesome presentation from Shannon. But if you see your name on this particular list, the co-host that is associated with your name will be contacting you shortly to give you instructions on how you can claim and receive the prize. Edis, Luis, Elka, Claudia, Elena, Catherine, Lizette, Randolph, Cynthia, Rebecca, Antoinette, Dina, Pitsavati, Brandon, Margaret, Lavinia, Jackie, Tana, Felix, Luis, Anne, Nile, Douglas, and Olivia. You are all winners of either a gift card or some other wonderful raffle prize from the corresponding Workers' Comp in Motion co-host. On behalf of Workers' Comp in Motion, we want to say again, thank you all so much for joining us today. Shannon, thank you so much for putting together such a dynamic and informative presentation. I know that it takes a great deal of effort and time to not only present the day of, but also to compile all of the great data and all of the great information in preparation for the presentation. So a very heartfelt thank you so much for Workers' Comp in Motion. Thank you all so much. We'll see you next time. Have a great afternoon.